Thank you. I'm Nilika Singhal. Nice to see you guys. I'm a pediatric epileptologist at UCSF, and I'm tag teaming this presentation with Lacy Smith, my colleague from Boston. That's a perfect segue to our portion, which is going to be discussing with you the PCDH19 registry, looking back at the last 10 years and where we hope to go in the future. So we'll talk about an overview of the history of our patient registry, our prior major projects, and future directions. So just to help define the term for everybody here in the room and on the web, a registry collects information from a group of individuals that can be accessed for future research. The purpose of this PCDH19 registry has been to collect genetic as well as clinical information into one centralized database and have this readily accessible patient population that ideally can be recontacted for future research or clinical trial purposes. Now, this is distinct from a natural history study that many of you may also be familiar with. The natural history of a disease, that term, it's defined as the course of disease that takes place in the absence of any intervention for those individuals with the disease beginning at the onset of that condition. And in that situation, patients are followed prospectively and data are collected systematically. These are pre-planned observational studies, and with the intention of tracking the disease course, they're often used as the precursor to clinical trials. So it's a little bit distinct from our registry. We feel that this has still been beneficial to maintain a patient registry primarily by means as providing a means by which to gather information to further understand this condition and to even think about identifying things that we didn't know that we would need to look for. And so our benefits are across multiple domains, as you can see here, for patients, for getting a better understanding of differences amongst individuals, to understand to better understand heterogeneity, and to help us in the field identify what are the high need areas that our patients are talking to us about. This helps us to understand surveillance, to understand a disease course through different snapshots, to understand more rare features amongst larger pools of people, and to think about what factors could impact quality of life and prognosis for any individual person. We hope to be able to learn trends in treatment to characterize differences across medications that we have available to us. And then it all comes back down to research. And so to think about interactive collaborations, generating hypotheses. So it's great to have folks like you here together in this room to help with that process as well. There are many challenges and limitations for conducting a patient registry. These data aren't systematic. We're not able to collect the exact same data in the exact same way from person to person. And so that can lead to some confounding variables or obscure what we're looking for. Determining what are the areas to focus on and the level of detail to collect information across people is a challenge. A lot of these are based on hypotheses that we have in the field of taking care of folks like kids with PCDH19 that led to the questions that we're asking to collect information in the first place. And then with that, there are large swaths of information, some of which may be less important and less relevant that we didn't know at the outset. So we may be kind of over collecting information that may not be useful to people down the road. Some of this information isn't totally verified. So, as you all know, these are some of the limitations with the registry itself. But to take us back in time, this started in Boston in 2014 with expansion to our site at UCSF. We've had enrollment at both locations, and we share de-identified information in a central database. And these data are collected by us requesting medical records from each kid involved in the registry. So we'll ask for neurology reports, neuropsychology reports, their genetic testing reports, EEG data, MRI images, et cetera. We also have questionnaires that we ask families to complete to understand symptoms and patterns for each individual kid enrolled. And that we're allowing registry participants to be recontacted to gather further information and or to notify them about additional studies down the road. So for our current enrollment, we have enrolled about 136 total so far. And this can be broken down, and this is across both sites, and it can be broken down, as you see, by 119 probands, which are the affected individual themselves, as well as 15 family members that were discovered to have a similar genetic change after identification of the kid themselves. And those are subclassified here. Some of this is hard to look at, like, for example, these symptomatic females within the family members might be considered as like a unique proband in and of themselves, but the way that we had collected information from the beginning, we're kind of lumping them into the initial patient that we contacted. So just wanted to flesh out that information a little bit further. And there are some general clinical features that we're observing that we wanted to share with you all across a few different pie charts here. So when we're looking at all of the folks involved in our registry, about 60%, a little more than 60% would endorse some degree of developmental delay. About a third would endorse some degree of intellectual disability, and more than a third would be classified under the autism spectrum disorder. Many people, as you can see, 72% are reporting at least annual clusters of seizures with an average age of onset at just over 12 months. We are observing trends that seizure frequency tend to decrease as children get older into the teenage years. This is not 100% across all of the people enrolled, but these are, you know, some of the trends that we're observing mostly. I'd love to turn it over to Lacy.
Great. So we thought at the 10-year mark of the registry, I can't believe it's been 10 years, we thought it would be a great opportunity to kind of reflect back on all of the projects that we were either directly involved with or the information in the registry helped to inform or stemmed from the information that was included in the registry. Or as I like to think about it, what have you contributed to as families who participated, and what have your data or what are your information in your children, what have they informed in our knowledge of PCDH19? So the first was our paper. This came out in 2018, where we published on the first, I think it was 38 participants in the registry. And this was really just a good opportunity to describe our experiences, to say, okay, well, this is what we're seeing so far. And it was really just kind of a descriptive analysis to say, these are the kids that we have in the registry, and here are the features that we're seeing and the numbers of each of those features. So we included 44 individuals, but the 38 probands that we had included are the 38 kids. And the breakdown was here. As you can see, early on, we had all female kids. We didn't have any of those mosaic males yet early on, but they came over time. And we also included those the parents as well and any siblings. So what did we find in this first paper? So as we now know very well, and we're beginning to really appreciate it at the time, it's this wide phenotypic spectrum, right? There can be a lot of variability even among females within the same family. So as you can see here, these are 3 different examples of 3 different families. And to orient you, the way we draw families in genetics is males are represented as squares and circles are females. And when you draw a line across here, that's a parental relationship, and the line drawn down is a child. So the circles down here would be a child, this would be mom, and this would be dad. Okay. So every time you have this little plus, that means that they have the PCDH19 variant. And every time you see a different color, I know it's a little bit small for those in the back of the room, so I apologize. I was trying to get so much information on this slide, but you can just appreciate that each different color represents a different symptom. So for example, red represents that person had seizures. Orange represents that person had autism. Blue represents that they had developmental delay. So the more different colors that are represented in their symbol, the more symptoms that they had. So you can see that this child had seizures and developmental delay and behavior challenges when mom didn't have any symptoms at all. And we can see that. We can see sometimes moms don't have symptoms. And we can see over here that this child had autism and seizures, but mom just had seizures. And you can see the differences in this 3 generations. So you can see a lot of variability. And we talked a lot today about the exon activation pattern, and we're understanding the mechanisms better. But we can just see here how that is really represented in the clinic or in our families. So in addition to this just kind of describing our own experiences, in addition to the variability, oh, and I put here an asterisk, some with epilepsy and no other features, because some of our families are enrolling in the registry so young that maybe they might present with seizures in the beginning, but maybe they're just really young, that maybe they are too young to start showing some of these other features. So I put this little asterisk here because maybe we just don't have that information because we haven't gone back to ask them, okay, it's been a couple of years, how are they doing now? Did anything change? And of course, you know, as we know so well, in addition to some of the seizures, there's the behavior that can be a big concern for some families, and the sleep that we were able to identify as well in a large number of these families. So beyond this, so moving on to some studies that some of our colleagues were able to do in tapping into the registry. So Christy Kolk, who is a colleague in Australia, so she did a lot of her doctoral work on PCDH19, and one of these was doing a more standardized approach where she was able to administer validated surveys to some families, and she reached out to us and say, hey, can you pass this study along to some of your families in the registry to see if we can increase our numbers, to see if there are any other, so to get some more families involved. And the benefits of using validated measures versus just describing kind of anecdotally or just what we're seeing in neurology notes and patient and family questionnaires is really a standardized approach. So if your child has ever had, excuse me, for example, a neuropsychiatric evaluation, they do these really standardized measures. That's similar to her approach to what Christy and her team did. So it's really a good way to get an actual score at the end to be able to kind of tally up and compare different kids. So these are just a list of the scales that they use. If there are anybody, I know there are some psychologists in the room who probably are interested in looking at that, but those are some of the measures that they used. And of course, again, a breakdown of just the individuals that were included. So some of the findings from that study, again, some of the similar features, right? It's a really distinctive clinical picture with the associated autism, some of the behavior things with or without ID. But some of the things that came from Christy's work in this paper and some of her other work in looking at PCDH19 was they were really starting to make those clinical associations, right? So oftentimes when we see these families in clinic, they get maybe it might be an early diagnosis, maybe the genetic testing was done at the first seizures and they get that genetic test report back. The question that we always get from families is, okay, well, what's going to happen? Or I know there's a wide spectrum, what's my child going to look like? Now we are starting to get some of the data back to say, okay, what are the associations, right? Is it just a genetic test report? Well, now we know that your genetic test report is only going to tell you so much because we know that there's a lot of variability. What individual clinical features in your child can be predictive of their own outcome. And that's what some of the work that came from some of these studies. So for example, it was the earlier age of seizure onset is really the most predictive of overall outcome. And just some of the other findings here that, you know, the heterozygous females and mosaic males are the same. And that was just really a larger study to kind of show that initial clinical suspicion that we had. Okay, so those are some of the initial projects that came from the information in the registry and the participants that were included. So kind of moving on to some of the more recent and ongoing projects that we have in the pipeline. So kind of stemming off of some of the work that was just presented. So, you know, going into some more of the MRI information. So we have a really great pediatric neuroradiologist at Boston Children's who has an interest in genetic epilepsies. And we know historically that when you have, you know, a structural brain malformation and genetic epilepsies, those are often considered mutually exclusive. But now we're really starting to appreciate that you can have some of these brain abnormalities and a primary genetic epilepsy. You know, we've seen that in other genes. We know that to be common in genes like SCN2A. So now we are kind of, we're more apt to think about, hey, even if there is a focal cortical dysplasia or malformation of cortical development, that there could still be a primary generalized epilepsy, or a primary genetic epilepsy rather, going on. So anyway, so we have a pediatric neuroradiologist, Ed Yang, at Boston Children's, who has a particular interest in genetic epilepsy. And he had noticed in the literature that there are several case reports of individuals with PCDH19 and who had focal cortical dysplasias. So these are focal cortical dysplasias are areas of kind of this abnormal brain cell organization and development. So just like kind of one spot on the brain MRI in individuals with PCDH19. But there's also kind of a lack of clinical correlation with some of this information. So for example, how do these brain MRI findings correlate with EEG? Are they clinically relevant? So he wanted to kind of more systematically evaluate the prevalence of these brain MRI abnormalities in PCDH19 and correlate those with some of the EEG data that we also had available. So he kind of interrogated some of the registry data, and this was a while back when we had 60 participants, 37 of whom had good enough quality MRI data to be able to go in and look at this. And of the 37, 5 of those had radiographic abnormalities. All right, and so this is where I'm going to admit, like, it's over my head. So I know as I get into some of these studies, those who kind of are the primary people who can, you know, discuss this a lot more eloquently than I can. I am not a doctor, I'm not a radiologist, but I will just gloss over this to the best of my ability. But I will hopefully highlight some of his major findings and conclusions, and go from there. So among the 37 patients whose MRI data were reviewed, so we had the 5 that had some sort of regional signal abnormality, and those are highlighted here. That was either suspicious for dysmyelination or FCD. So for 4 of them, these abnormalities were concordant with at least some electroclinical seizure data, so I highlighted those here. And in 2 of those cases, which I highlighted here, hypometabolism co-localized with the MRI abnormality. And one of these patients underwent a resection, so and had brain surgery. And we'll hear more about that patient in a few minutes. But so some of the conclusions, at least from this MRI study, and again, this is a kind of a gross MRI study, so this wasn't as detailed as the one we just heard about, but we found that structural abnormalities can be present in a small percentage of individuals with PCDH19, and these findings might be clinically relevant as they might correspond with seizure onset or seizure localization. So PCDH19 can represent another genetic epilepsy in which a finding on MRI, should not rule out an underlying genetic etiology. So, and furthermore, epilepsy surgery which is just a question we brought it up a couple of times, isn't necessarily off the table for those with PCDH19. And with that, we'll talk more about that.
Okay, thank you. So, piggybacking off of that, our collaborations led to this one description of a publication of folks with PCDH19 related epilepsy who underwent epilepsy surgery as a treatment option. So I wanted to speak to that for a few minutes with you guys. This was a retrospective review. So it was in retrospect looking at the clinical situation for 3 people with pathogenic PCDH19 variants identified. What these folks all had in common is that they all presented with seizures in childhood. They all had one consistent seizure semiology. That means that every seizure that they had looked the same every time. They weren't having multiple patterns of seizures. They became medication resistant, which is characteristic of folks with this condition. And they were found to have consistent imaging findings and EEG findings. And MRI findings were kind of all pointing to the same area in the brain. So all three of these folks underwent, they all wound up having temporal lobe epilepsy and underwent temporal lobe resections, resulting in seizure freedom. It's three people. It's obviously the minority of the folks that we are taking care of with this condition, but we thought it was meaningful to describe what could be potentially useful in people when all these things are lining up to afford surgery as a potential treatment option. So in radiology world, right is left and left is right. So this is where my arrows, this is the right side of the brain for this individual, and you're looking at them face on. It's like they're standing up in front of you. This is the right side for this individual. This is the right side for this individual. And on these first two people, their right temporal lobes looked different than their left temporal lobes for both the MRI and the PET scan. And then for this person, the left side looked different than the right. So in radiographic, terms, this asymmetry wound up being a meaningful finding for these people because that fit with the pattern of seizures that their brains were producing and fit for their EEG findings as well. Interestingly, as is done with anybody who undergoes brain surgery, the tissue is analyzed in pathology to look for what could be there structurally and pathologically different about that brain tissue. None of these three people had cortical dysplasia, which is what you were talking about, that pattern of changes in the way that the brain has formed that you can observe in pathology. One of these people had something called hippocampal sclerosis that can be a chicken and an egg. Sometimes that can be the cause of someone's seizures, and sometimes that pattern can happen because somebody has had temporal lobe seizures for a long time. So one person had pathologically confirmed hippocampal sclerosis. One person had this otherwise non-specific white blood cell infiltrate, and one person had gliosis with some cell loss of the hippocampus. So different findings for each person. Of those folks, one person was sort of lost to follow-up after 6 months, and so we don't have long-term information about what happened to that child, but the other two people were able to reduce their medications and even come off of medications. Importantly, as far as we can tell, so far of trending these folks forward in time, there weren't any observable problems after surgery. So no major cognitive declines or decline in social functioning after surgery, indicating in the super tiny sample size of only 3 people, it seems that maybe it's potentially safe and not detrimental to undergo that type of treatment option. Again, when all the stars are lining up as affording that as a treatment option for people.
So going back to the clinical side of things and understanding what's happening from a symptom standpoint, there are many different approaches to kind of better understanding the clinical features associated with a particular condition. And the gold standard in terms of clinical trials has always been these natural history studies that we talked about earlier on. So, however, these studies are often time and labor intensive. They involve enrolling and following families prospectively long term. But what if there's a kind of another way to do that and collect similar type of information and similar types of data, in doing that for larger numbers using information that we already have, and specifically information that we have in the medical record. So this was a process that was kind of really developed and really kind of investigated a lot more by Ingo Helbig's group over at the Children's Hospital of Philadelphia. And this is a study that's kind of just getting off the ground now. So this is a collaboration with CHOP and along with Heather Mefford at St. Jude to do kind of this, what we call systematic HPO phenotyping across a large number of genetic epilepsies. This has been done already and published for STX-BP1. And we're kind of expanding this to a number of different genetic epilepsies and PCDH19 being one of them. So what is this? What is HPO? So HPO stands for the Human Phenotype Ontology. So what that does is it provides, it's like another language. It's like clinical symptom language, and it provides a standardized vocabulary of phenotypic features that can be encountered in a specific condition. And it allows also for the harmonization of clinical data into a singular form. So as you can see here, it's kind of small, but these are in the blue bubbles, you see different clinical descriptions, and they're all kind of being collected into a HPO term, which is a string of digits or a number. And that is a way to create a code or in order to annotate them in a standard way. And by standardizing that, you can further analyze them. Anytime you can put a sentence or a list of features into a data point, that means you can do an analysis, and that means you can make mathematical sense and create a graph or a timeline and look at it in different ways. So HPO can also map connections between related terms and fill in gaps if detailed clinical information is missing. So, for example, you can see here take seizures, for example, right? There are different seizure types. You might have very detailed information on seizure types for one child, but you might only know that another child has seizures. Well, then you can't compare them, right? But yes, you kind of still can. And you can do that in a way because HPO terms are related through this ontology in which terms are mapped to a parent term, right? A very detailed clinical description such as a generalized tonic-clonic seizure or an epileptic spasm is related to a seizure because those are seizure types. So you can map those up to its parent term. So those are ways, and you can calculate mathematically how related different terms are. Again, that's about the extent to which I can describe that. So if you'd like to learn more, I can point you to these references, but there are ways to do this and it's been done. And I think that the point is, you can compare overall phenotypes by calculating how similar certain features are. And there are a couple of different ways that we're planning to do this. And again, we're working with colleagues at SHOP who've kind of created this approach. And there is what we call our static phenotyping and longitudinal phenotyping, where static is kind of like a snapshot of clinical features. And that's basically a baseline information on lots of individuals. So has this patient ever had X feature? And it's a comprehensive list. So that will give us whether it's onset or offset, and regardless of age that person had it, have they ever had these features? And it's a list. So that's will give us an overall kind of clinical picture for PCDH19. And then the longitudinal is following a fewer cases over time. So that's basically a timeline of when features onset and offset. So I put this teaser in, which is no longer a teaser. So I feel like I should give a little bit more information. So this is a lead-in for Archana's talk, but as we know, Archana is not able to be here today. But we are working with her because she has developed a mechanism to look at exon activation patterns in people. So no longer in the mice, but actually in people. So she had reached out to us to see if we had any families in which there are multiple individuals who had PCDH19 and whether there were any what we call discordant phenotypes, or is there a major difference in the clinical features in the different individuals within the same family, in order to look at the variant and look at the exon activation pattern within the individuals to see if there was anything there that we could conclude based on exon activation patterns and differences in phenotype. So I think that's what she probably was going to talk about. I imagine, and again, she probably would have given us a great talk on her methods and how she was going to do that. And maybe for next time. Maybe she'll have lots of data next time for us, though. Okay, and then for future directions, so she can do that. All right. Whoops. Oh, there are future directions. So, we just wanted to think about it and acknowledge that there are lots of different efforts underway, doing kind of similar things. So we know that we had talked about the citizen group, and there's this organization called the National Brain Gene Registry. So different groups that are kind of looking at and pulling together groups of individuals with a similar diagnosis. So pulling together individuals with PCDH19, for example, and collecting records and clinical information and creating this centralized repositories in different ways. And I think that that's a lot of kind of duplication of efforts. And I recognize if families enroll in multiple different studies, that's participation fatigue. And we recognize that that's a real thing. And we don't want that to become a hindrance on our ability to collect information and do work if you all are spread too thin, and if we're kind of duplicating efforts, are we reporting on the same individuals, thinking that they're two different individuals, and we just wanted to open up the conversation on how we can work together with these groups and where the registry fits in here, and how we want to have all these groups like work together and collaborate and find out the best approach for this group moving forward.
Just to highlight that again, so looking at broader more national organizations who are taking deep dives into specific genes could be really useful partnerships for our group for PCDH19. And then the other approach that is underway is another mechanism through the Pediatric Epilepsy Research Consortium, PERC, working on building something called a learning healthcare system to link pediatric epilepsy centers throughout the US to have like a more automated format of sending data and then also answering comparative effectiveness questions. Like if you're comparing the ways that we're using medications to treat seizures across the country, are kids everywhere getting the same standard of care, and what are the differences? So that's not taking a deep dive into one condition, but more looking at all of the data that we're collecting at the point of care when we're seeing a kid in clinic and looking at it from another perspective. So there are a few different approaches. These listed here are deep dives into our gene of focus. And then other groups are looking at the more like meta, big picture of how to deal with data in the electronic health record and maybe make it work for our patients and not just for billing.
So with that, we wanted to thank you all, and thank you all for participating and contributing to such amazing work. And with that, we'd be happy to take some questions.
I can babysit. Okay.
Jennifer Wickenwerder, I've reached out to you before, but you don't have my information. And the only reason I ask about that is, you know, she's good, as a mother who, she's now 21 months old, but at the time she was newly diagnosed, and I reached out. I found the process very overwhelming and trying to do the questionnaire, and I was dealing with a new diagnosis and just trying to find someone who understood even what she had, right? Is there any way that you could have a questionnaire where I can like log in when I've got 10 or 15 minutes? I mean, that's like a long period of time, or something I can log in and work on at 2 o'clock in the morning when I'm up, that I can continue to give you that information, because I would love to share the information I have with you. But the method to get it to you is daunting for me. And I would love to help the community, but the method just is challenging. Any suggestions or anything that you might be working on?
Thank you. That's a great question. I think I need to leverage the power of the 20-year-old brains of medical students that I work with and have them do like a QR code that, yeah, it's a great thought. It's really cumbersome as it is. The questionnaire is 20 pages long and really detailed. So I can totally empathize with how challenging it is, but yes.
No longer have my
Yeah, and I think we had a lull in sending it out because I think we were trying to optimize that questionnaire and making it electronic. So I think we do have one now, but it's still in the works of kind of being implemented.
So we got the share.
Hi, I'm Shauna. I have Lila who's almost 16. So just to add on to that, I've tried, I think, reaching out a couple times to try to just update information because when I did the registry and what we've been through since then, it's, there's so much new information, so many more medications that we've tried now. So just, I guess, similar to that question, is there a way that we can periodically and without it being too burdensome, electronically update our data at certain time periods every few years, or at least have that option where we don't necessarily have to bug one of you in order to do it. And then I guess my other question was just about treatment and medication. And I sort of expected to see maybe some of that in this presentation in terms of updated data on effective treatments, whether it's medication or VNS or other things. So I'm wondering if you have any of that data, even if it's not officially in a study that's been published.
Yeah, great thoughts. I think that I also would love to have like a systematic way to recollect information every couple of years about the kids enrolled. I wanted to just reaffirm that all the kids that are enrolled in the registry the information is there. So should a trial or should a new treatment or should a partnership emerge, that's really valuable to have your kids as like as folks to contact as needed, with partnerships that would emerge. So I'm glad that at least the one point of contact exists for this being a pool of people to reconnect with. But yes, I think that in this era of QR codes and using things more efficiently from your phone, that would be like the future state for our registry, is to have people be able to enter information at your own time and then to update it also. We didn't include information about treatment patterns because to your point, we haven't collected a systematic comparative effectiveness style trial. Like we've not really said, okay, for a new diagnosis, half the group is going to get X medication and half B medication. And let's actually answer that question about which one is more useful. So this registry doesn't provide that type of information. And just on the basis of observing, the usual motley crew of medications continue to be used based on individual features, like what type of seizure your kid is having, what are relevant side effects that impact your child. And we haven't seen like a real gold standard standout that is associated with like a dramatic improvement in one group versus the other. So we didn't include that information just to not give a false portrayal of a treatment being like the go-to or something like that.
Yeah, and some of the challenges and limitations that we had talked about, it was a balance of, okay, we can ask lots and lots of questions to try to get information, but what's the cutoff of asking so many questions to gather the information and which topics would be focused on versus making the questionnaire too long and too cumbersome that families wouldn't complete it, right? And it's like, which areas do we focus on and versus getting the type of clinical information to get a sense of the phenotype of each child. And then if there is an additional study that wants to target a specific question, then we can reach back out and start asking those specific questions. Because if we ask too many questions about everything, then it's going to be a 45-minute questionnaire for families to fill out. And it's going to be overwhelming if we're asking that level of detail. For parents of older kids, it's like, oh, we've been on every medication and I can't answer these questions because she was a little baby. And so I think we weighed that a lot, and it's a balance of how much is too much to ask versus we want to get the information.
And maybe Neil, can you speak to the learning healthcare system a bit? I mean, I think we are in this, right, everyone has to have heard of AI, might even know. I don't know what that is, But these large language models, right, that can analyze huge data sets in a way is only going to improve pretty quickly. And I think we're already seeing pharmaceutical companies use medical claims data as like a surrogate marker for healthcare utilization. So for example, if you knew someone had PCDH19, you can now know how many times have they gone to their Walgreens and filled their Keppra. And if that only was filled for 1 year versus 10 years, maybe that could be a suggestion, right, that Keppra was working better, although you can see there's probably flaws in that sort of analysis as well. But I think this large language model, maybe together with the learning healthcare system where we're refilling prescriptions, and if we have the button that we click that says PCH19, maybe there could be some patterns that are seen. I don't know if that's something that is looking forward for the epilepsy learning healthcare system.
Yeah, I think that question among so many others of like what are appropriate rescue medications or bridge medications for when your kid is sick, or continuous infusions versus steroids in the emergency rooms. There's so many prescription patterns that will emerge, and I think that the infrastructure of trying to link epilepsy centers across the country will answer those, not just for PCDH19, but so many more rare conditions too. And then they're just looking at the Q&A online too. There are questions about how to enroll. And so a lot of this has been via the Alliance, like advertising this registry on the website. And then many of the people enrolled are not seen at UCSF or at Boston Children's, but are from other sites who have heard about it through word of mouth or through parent groups to raise awareness for this. But it is sort of dependent then on, or people contact us or their neurologist mentions it to them. So it's sort of bi-directional, but my feeling is that in many cases, it's families who have heard about the registry through the Alliance and through word of mouth that they're reaching out to us for participation, as opposed to every neurology clinic advertising that this exists. That's just based on my observation. So in other words, we're probably missing people.
Yeah.
We're probably missing the kids who don't need to see the neurologist that often or something like that, or aren't as involved in the community.
And I have one question that can maybe bring everyone together here in terms of the radiology paper, right? So 5 patients with, maybe we could go back to that slide. So 5 patients that had possible MRI abnormalities. And then we know from our surgery paper, none of those were focal cortical dysplasia, right? So we have an MRI finding that would suggest what we as epilepsy providers would think would be focal cortical dysplasia once the tissue's looked at under the microscope. From a radiologist perspective, and then our mouse scientists, could these imaging things be areas with more striping? Do you think? Would that cause, I mean, if I think, right, Julie, about our patients that have type 1 FCD, and you look at their tissue under the microscope where just the axonal projections are not as linear and you have disruption of the nice 5-layer cortex, could that actually, if this striping and co-localization of these columnar PCH19 positive negative, could that be, I mean, I can't see these images, but I think we have to trust Dr. Yang that these were real findings, and then we have some tissue and it was normal. So, but they're obviously not looking at predicate hearing under the microscope. So I know there's probably not an answer. Could it be?
I wanted to ask if they found the mutation in the cells that were examined after the surgery, because, for example, the focal cortical dysplasia is associated with the mTOR pathway, is very known, but maybe there is a role of the protein itself in the development. I don't know, but I don't know. I was asking if they analyze it.
I don't think they did any additional genetic testing on the tissue after surgery, at least for my patient.
Yeah, same. It's a great question.
Probably to get this wrong, there was Amperi's group published a paper not that long ago, looking at focal cortical dysplasias and cell mosaicism, and there were PCDH19 mutations were found fairly frequently in patients who had stereo EEG with focal cortical dysplasia. So there, I think it's
possible. And then in the surgical specimens, I think it would be very interesting to see if there are stripes or if there are more areas of PCDH19 expression, or clustering of PCDH19 expression in those surgical specimens. That would involve validating an antibody to work on there versus doing, in situ hybridization to try and see like what the expression pattern is in the surgical specimens, which is something absolutely that can be done, but it's very valuable tissue, so we want to make sure we're doing it right the first round. And I guess to answer the question of, what do you do for control tissue? There are a lot of human brain surgical specimens from non-epilepsy surgeries, right? So you could conceivably use like normal brain tissue that had to be resected to get a tumor out of a patient. You could use that brain specimen as your control to look at PCDH19 expression if it was in a similar brain region. But it definitely, there's it's low numbers, so trying to like interpret it appropriately I think would be challenging, but I think it's doable and would be at least interesting to understand how PCDH19 plays a role in some of these resectable tissues.
Can you hinted at the exit activation that was going to be in the next talk, but obviously available now. What was this is sort of related to what we're talking about, but also maybe not. What's the tissues that we're looking at for exit activation? Are we talking CNS or blood or?
No, it'll be either blood or buccal.
Okay.
Yeah, so it's not going to be necessarily the best representation of what's going on in the brain, but I think that'll be a limitation, but maybe a starting point.
I have two questions. I'm Jennifer. My daughter is Jane. She's 12. She actually has been diagnosed with multifocal cortical dysplasia before her PCDH19 diagnosis. But we kind of wanted to know, how do we get involved with the exit inactivation study that is going to happen? Because we both have it as well, and for the very different things of our children. And then also, what did you mean by blood or buccal? What's buccal mean?
Yeah, so those of you who did your genetic test, oops, I don't know where this is coming from. Years ago, you might have done a blood test to get your genetic test done, but those of you who done it more recently might have done a cheek swab. So buccal is just the cheek swab. So you can get DNA from either place. So that's just sometimes blood is more, you get more DNA that way. So sometimes the buccal, you just don't get enough, so you might have to repeat it. So blood is ideal, but obviously buccal sometimes is just obviously easier and you get less of a fight from your kids. So it's obviously the more ideal from a feasibility standpoint. And in terms of getting involved in the exit activation study, we have it's still very early on, and we're still trying to look at family structures and looking at the variants and which variants I think that she's doing something with the variants. I don't remember. Sorry. But in looking at families, and I think we're going to use this meeting as a time to connect again and look at the number of families that you would want to include. And also, there might be a time that we reach out to families again to gather some more information and get a little bit more update and invite families to participate in that. And then it might be an additional, so we're going to use the registry to recontact, but it might be just an additional consent to get, because the registry, we don't have consent to get any tissues. So it might just be another consent process just to allow us to collect tissue and be able to do kind of genetic studies, because the registry isn't a genetic study, it's kind of an observational study.
May I ask you a question? The multifocal cortical dysplasia, is that based on MRI? There's multiple areas, or based on PET scan? Okay. Okay. So this is where I think, right, these, as radiologists, it's like in an epilepsy population, when we see this blurring or we see a PET abnormality that looks more we kind of go to the most common thing, which is cortical dysplasia. But cortical dysplasia is a under the microscope diagnosis, right? So I think what we've learned, at least from the few patients that we've taken to surgery, it's actually not cortical dysplasia, right? So this is what I think is so interesting, right? So is there something about the PCDH19 expression in those areas of the brain that are being hypometabolic in PET scan that may explain that, and may explain some of the structural imaging abnormalities? So that's not to say, so just, I would maybe say that, well, I don't want to make a medical opinion here, but so it's probably not multifocal cortical dysplasia, right? So just, so it's not confusing the matters even more. It's imaging findings likely consistent with PCDH19 epilepsy, right? Any closing comments? All right.
Just a curiosity, I'm just wondering how many resections have been done on kids with PCDH19 across the world?
It's a great question across the world. At our hospital at UCSF, only 2. Boston
Just our
1.
That makes
This is on the order of reports. There are a couple other individual reports of people that might have undergone surgery, but I think the numbers are super rare overall, at least from what's been published.
To share the one caveat from our one UCSF patient, was kind of an interesting story because the aunt who went to the surgery, I was following her niece, and literally this is when genetic testing was really difficult to get. The week that this aunt was presented at our epilepsy surgery conference, we got the genetic testing result back in her niece. And an epilepsy surgery conference, there was a big discussion. Wait a minute, this is the aunt. She has childhood onset epilepsy. She has to have PCDH19, and we were a little bit reluctant to move forward with surgery. But the aunt is like, I want surgery, and moved forward. And for her, again, it was the right decision. But it was so we didn't know that she had PCDH19 at the time that her surgery was done, and we should have been more forward thinking. This is like 2014. Right, we should have been more forward thinking about trying to preserve that tissue in some way. It has been the tissue, like, as these specimens are removed, they're frozen and they're stained, and so the tissue still does exist, but it's all in paraffin and fixed and not of good use to our scientists anymore. So. All right, well, if there's no further questions, I think I'm the only thing keeping you